Hi, my name is Dusty Lynn, and today we're going to talk about the extremes in trauma, the contrasts, and the commonalities. I know you've probably heard, as I have my whole career, that pediatrics are not just small adults. And that is so true. Their physiology is different, their anatomy, of course, is different. However, while serving as a trauma coordinator, taking care of both pediatric and adult patients in trauma, I realized that there were some striking similarities that are important to keep in mind when dealing with both. So our objectives today, we are going to review the differences in the physiologic trauma response between pediatric and geriatric trauma patients. These are the things that we know to be true about the differences in those patient populations. However, we're also going to identify 5 main points about the commonalities of both specialty populations as they're related to trauma. So one salient point to remember, both pediatric and geriatric trauma patients are considered by the American College of Surgeons to be a specialized population, and they really should be treated in trauma centers that deal with the specialty population of your patient. So we're going to talk about mis-triage. We'll talk a little bit about the trauma assessment process. We'll talk about how shock is easy to miss in both these patient populations. We'll talk about the physiologic and anatomic changes that could mask the severity of the injury. And then we'll talk about non-accidental trauma. So there you have it, your 5 main points as to why these patient populations might be more similar than you realize. So we'll talk about perspectives here. Of course, there's always those extreme, the 80-year-olds who run marathons and do triathlons, and you have the tiny, teeny extreme preemies. We're not talking about either one of those extremes. We're talking about the extremes in normal, in that your infants and some toddlers, as well as your geriatric patients, as you think of most geriatric patients over 65, and as they get older, their health becomes more frail and fragile. Those are the patients that we're talking about. So again, between your pediatrics and your geriatrics, the American College of Surgeons calls these specialty populations. They have very distinct differences in their needs, and therefore distinct differences in their trauma response. And so it's important that they be seen in centers who are familiar with that particular population. I mean, just look at this slide and see how we come into this earth and how we live our life and progress, and then how we kind of digress and regress, and oftentimes can end up in the same situation. I just thought this was a poignant reminder to be kind, because it is a big circle. So again, one of our main points are the fact that both patient populations, pediatrics and geriatrics, have the common problem of mis-triage. In the pediatric patient, sometimes they can have a very subtle response to severe trauma, and we can miss it, or they may not present as quickly as they should. They could have delayed presentation. In the geriatric population, their pain receptors can be dulled or decreased, and therefore they don't feel the pain that the average adult would feel, and so they might have a delay in presentation. And we'll talk about some physiologic changes in the brain as well that might cause a delay in presentation for traumatic brain injuries. So let's talk about the commonality, the causes, and the mechanisms of trauma. So your infants, they could have abuse, non-accidental trauma. There's falling, and your toddlers, burns, and poisonings. Some centers consider that quote-unquote trauma. Geriatric patients, certainly you know their mechanisms oftentimes are falls. They have abuse as well, and they could have burns, and they can have overdoses, sometimes because they forget that they've taken the medication, sometimes because their physiologic responses to medications is slowed and the dose needs to be decreased. So let's talk a little bit about falls. In the younger patients, we know that their falls are usually from greater heights. They crawl up things, they're very head heavy, so they tend to fall head first. and therefore you see the injuries there. They're falling from higher heights and they're leading by their heads. However, the elderly person, when they have a fall injury, it's more likely a ground level fall. They're standing and they give way, they become syncopal, or they trip over something and they fall. And so their injuries could be very different. But what's a main point to remember? The processes and the priorities are the same in both patient populations. For traumas, you always, from the minute you walk in that room and see that patient, or that patient is coming to you, you're looking for C. Do you need to control any hemorrhage? Is there any exsanguination that's happening? Control obvious life-threatening exsanguination. And then, of course, you want to make sure that you take care of their airway, with remembering that to protect the C-spine. You're going to assess for their breathing. And again, you're going to check their circulation at a much more finer point now and look to see if you've missed any uncontrolled bleeding. Their disability and their neurologic status, as well as things like exposure when we're looking head to toe for any other injuries. All these processes are the same, whether it's a tiny infant or a geriatric patient in their 90s. Our priorities are the same as well. We must avoid hypoxia. Both patient populations can become hypoxic and we could miss it and not know it if we're not paying attention. So don't hesitate to give oxygen when needed. Avoid overventilation. This is very, very important. Both patient populations are very sensitive to positive pressure, and so when we bag them, we must be very, very careful. They both can be very difficult. With infants, sometimes it's hard to get the right size mask. With your geriatric adult who might have missing teeth, mustaches, etc., it can be hard to get a good seal. It's easy to cause pulmonary injury when we're bagging them with positive pressure, so we must be careful for this and make sure we're monitoring the pressure that we're putting in them, and that we're monitoring their capnography, their end-tidal CO2, because you want to keep their CO2 within normal limits. IV access and intubation can be very difficult on both, and we'll talk about that a little bit more. And we need to avoid secondary brain injury. Very, very important. Both are very sensitive to extending that initial injury in their brain just by their physiologic responses and our lack of vigilance in watching those responses. Both populations are very prone to rapid hypothermia, and you know what that means in the trauma patient for acidosis and such, so you have to be very careful there. So if you're looking at these pictures, you see their C-spines. There's some commonalities. They're challenging. With babies, they have these big heads on these lax little necks, and it's easy for them to have neck injury. Their heads are much larger. Because of that, they can have what we call scawara, spinal cord injury, without radiologic abnormalities. All that means is you can take an x-ray of a neck in an infant, and the bones look like they're fine, but the spinal cord itself could be injured. It could actually be torqued and not a bone broken. So being mindful for that. Ill-fitting equipment. I see kids come in sometimes and they have a C-collar on and it's actually occluding their airway more so than protecting their spine. So you have to be very careful for that as well. Infants, when they're in trouble, may not like laying flat on their back. And when you think of the elderly population and their frail neck bones, you can actually fracture the neck of a person with kyphosis or C-spine abnormalities that is just their baseline. Just by trying to kink them back too far or moving them suddenly, you can actually cause a fracture. So you have to be very careful in the extreme elderly population for their neck frailty. They may not be able to lay flat either, for obvious reasons. And both patient populations, when you put them in a collar, if it's not fitting correctly, can get worse. And so again, this is why you want to monitor capnography for perfusion and ventilation, as well as your pulse ox for your saturations. Anytime we're doing interventions with these patients, as well as just we want to keep an eye on them, you need to monitor them very closely. Now we know in the pediatric airway, it's very different than the adult airway. The narrowest part is below the cricoid cartilage, and it can become occluded easily. The number one reason for airway occlusion in the pediatric patient is that big floppy tongue. just remember that when a patient, any age, but especially a pediatric patient because their tongue is so much larger, anytime they become lethargic, not only are they lethargic throughout, but the muscles that hold that tongue out of the airway is also lethargic. So just laying flat on their back, if they're lethargic, can occlude their airway. So we must watch them. We must monitor them closely, again, with SATs and capnography. So what are the commonalities in the airway in the extreme pediatric and extreme geriatric patients? Both of them are very easy to bleed. In the pediatric patient, their oral pharyngeal cavity is very vascular, and so it doesn't take much to scrape it with an oral airway, suction it and cause bleeding, and become an airway risk. They're at risk for aspiration just because of their airway size and their location. Geriatric patients, very easy to bleed because they oftentimes are on anticoagulants. And so because of that, it doesn't take much to cause trauma to them and make them bleed. If you ever listen to a older person and they're always clearing their throat and such, oftentimes that means that they have baseline aspiration just as an everyday. The cilia in their airway as they get older doesn't work as well, so it can't sweep out the little things that we breathe in every day. And like for me, allergy season right now, they can't clear their airway very well. So they've got this constant baseline aspiration with decreased cilia movement, and they are at higher risk for aspiration than the average adult. So some of the challenges, as well as some of the commonalities, again, infants can occlude that airway very quickly because of the smaller diameter and that big tongue. They could have missing or loose teeth depending on their age. They have this large occiput that, again, as they're laying down, it can occlude their airway just by pushing their head forward. And they could have a fear of laying flat. The extreme geriatric patient can also occlude their airway. Now, their airways aren't smaller, but they're floppy. Again, as they get older, their tracheal structures become floppy and aren't as easily to control their airway, to cover it, to prevent foreign bodies. So they're easy to aspirate, again, as well as the fact that they could have borderline aspiration. And if you think about the oral cavity of the extreme geriatric patients, sometimes they have dentures, they have partials, they have bridges, sometimes loose teeth. And you have to be very careful because all of those could cause foreign body aspiration as well. And as you can see in this picture here, the curved spine may preclude them to be able to lay down and to optimize their airway. They can't necessarily lay flat, so you have to be very careful for that and accommodate them. So airway intervention, some of the commonalities: we must avoid hypoxia. They could become hypoxic and we not know it, just think they look a little pale when actually they are having a lack of oxygen. Trying to bag them could be very difficult, so be prepared. Anytime you have enough hands that you can do a two-hand technique when you're bagging someone with positive pressure, it's always a better technique. Go for it when you have that. It's not a matter of pride that you can't get a good seal. It's just easier when you have two people. So if you do, always do that. And beware foreign bodies. Again, your loose teeth, your bridges, your dentures. Intubation could be challenging for both. You certainly want someone who's experienced in pediatrics to intubate the pediatric airway. And in geriatrics, geriatricians and ER docs, anesthesiology, etc., who are familiar with geriatric C-spines and recognize that they can't move them but so much because you could actually break their neck, is kind of important. So that's who you want intubating these patients. The drugs that we give for rapid sequence intubation may well need to be adjusted on both extremes. Normally in pediatrics, we just give a per kilo dose, usually not a problem, and we have our adult doses for our adults as well. But in your babies and in your geriatric patients, both could have decreased metabolism or uptake of the medication. They could have an increase as well, and they could just be more sensitive to the medication. So oftentimes we will start low and go slow. It's always easier to add more medication than to take it away, so be careful with that. They're both at risk for aspiration. One of the things to remember, especially in your toddlers and such, is they need their bellies to breathe. So you don't want to occlude them. I was taking care of a pediatric patient once that came into the ER, about 6 years old. Flight medics brought her in, and initially when they landed on the pad, she was talking to them. She wasn't intubated yet and doing okay. By the time they got her into the emergency room, they said, I think she needs to be intubated. She's not as awake as she was. Her Glasgow coma is dropping. So we're preparing to intubate her. See this 4-inch tape across her belly. This was in the day of backboards, and it was pretty tight. And that's all we're thinking is, gosh, that looks tight. So they're literally getting ready to intubate. Laryngoscope is open, stylet is in the ET tube, and we just reach over and cut that 4-inch tape because it just looked too tight. The child took a deep breath, started to breathe better, started to mentate better, and did not need to be intubated in that moment. We could wait till we got her up to the OR. So again, kids need their bellies to breathe. You don't want to occlude them or cause pressure, which would also cause increased aspiration. And remember the positional limitations of both the extreme populations, and recognize that their C-spines are at risk for injury. Infants and children more for the cord, and the extreme geriatrics, actual bony processes, as well as the cord. So some of the common causes of death in the trauma patients, as you will see here, immediate causes: hypoxia, aspiration. They make it through resuscitation afterwards. If they die, oftentimes the challenge again is aspiration, hypoxia, and pneumonia. So let's talk about breathing. Look at the similarities here, right? Now let's talk about the contrast. So in the pediatric patient, their respiratory rate varies with age. If you're not really sure about what the respiratory rate of a 6-month-old should be versus respiratory rate of a 5-year-old, carry a reference. It's very important to recognize that a respiratory rate of 50 in a newborn might be okay. A respiratory rate of 50 in a 4-year-old is not okay. So their respiratory rate varies with age. Often when kids get in trouble and they start working hard to breathe, you will see major retractions because of all the cartilage in their rib cage. So they can really, really retract. This is why it's so important when you're doing your trauma survey that you expose your patient. If they're covered up in a gown, you might see just a little bit of nasal flaring and not look bad, and then lift up their gown and see this patient who's really, really retracting hard. I saw a child retracting so severely once that I swore the only reason why he had any kind of heart rate, because he was that ill, was because he was doing self-chest compressions because he was breathing so fast. His respiratory rate and his heart rate were the same, and he was really, really retracting. So very different. Those are the pediatric patients. They're more likely in trauma to have a tension pneumothorax. And remember, their ribs are so flexible that their ribs may not be broken at all, and yet that impact can cause a tension pneumothorax. And if you don't have a systematic approach for assessing these patients, you could miss that. Because if you go right from airway and then you're assessing their breathing and you look at their respiratory patterns and their work of breathing, you count the respiratory rate, and then you move on and you're doing central and distal pulses, and they have no pulses in their feet, and their cap refill is 6, and they're cool from knee down, and they're tachycardic, and you're like, cool, I got this. He's in shock. Let's put a line in him. Let's give him 20 per kilo, and he dies. What do we not do? If we didn't listen to the bilateral breath sounds, we could miss that, the fact that they had a tension pneumothorax. And kids in tension pneumothorax, it's a type of shock, right? It's in a type of obstructive shock. And they could look visually just like someone in cardiovascular shock. So it is important to have a systematic approach. So that's another presentation maybe next year we'll be able to do. Emergency assessment in the pediatric patient, one of my favorite presentations to do. But that's why it's so important to have a systematic approach, because kids are more likely to have a tension pneumothorax after trauma. So you need to observe for that as well. And as I said, their ribs are very, very flexible, and they could have severe chest trauma and not have a broken rib. So certainly if you see bruising, you really need to be thinking about internal injury as well. And babies are obligate nose breathers until they're about 6 months old. And what that means is they prefer to breathe out of their nose. It doesn't mean they can't breathe out of their mouth, and they will. But keep that in mind, because they're obligate nose breathers, and if they are in a trauma and they also have a cold, snotty nose, etc., and it's stuffy, and we put oxygen on there, they could become hypoxic because their nose is stuffy and they're not getting the oxygen they need. So look to observe how your patient's breathing as to where you need to put the oxygen is a point there. And again, they need their bellies to breathe. Make sure it's free enough so they can get that good thoracic excursion to be able to breathe like they need to breathe. Geriatric patients, little variance in their respiratory rate, pretty much the same as an adult. However, their ribs fracture very easy. And this was an astonishing statistic when I saw this, that in the geriatric patient, I'm talking extreme geriatric patient, for every rib that's fractured, they have an increase of 20% in their mortality. Think about that. So if they have 5 fractured ribs, it's not a good outcome. And the other thing to remember is we have to watch these folks really, really closely. So even one fractured rib, if everything else looks okay and we put them out on the floor and we're not monitoring them, they're not on oxygen, and they become hypoxic, again, hypoxia, aspiration, they could die. You know, they have a 20% increase just from one fractured rib. So certainly if there's more than that, we need to think about where we're admitting these patients. And they, of course, can have flail chest. So, the commonalities in respiratory in the extreme pediatric and geriatric patients, they both tire easily. They have weaker muscles, and they can tire out easy and not be able to breathe like they need to. Hypoxia may not be obvious. They're more likely to die from hypoxia and hypoventilation. Pulmonary contusions are likely in both. Pneumothorax can happen easily in both with positive pressure. So this is something that we could cause just because we're not thinking, wow, this is an infant, I got to be careful. This is an 80-year-old, I have to be careful. Be very careful when we're bagging them. They're easy, very easy to overventilate as well. We must use smaller tidal volumes when we're ventilating. And it is really hard to tell by chest rise how much we're ventilating. That's why you really need to monitor their capnography, their intidals, and just keep it between 35 and 40 if it's a head trauma, and 35 and 45 if it's the rest, not a head injury. So remember that the ribs are less protective. For obvious reasons, in this little guy here, you can see there's a lot there that is protruding that's not protected by those ribs. And with the extreme and geriatric patients, their ribs are just more friable and easily to break, so they don't protect as well either. So now let's talk about some circulation contrasts. With the pediatric patient, this is probably one of the most obvious situations. They don't have peripheral vascular disease. They usually have very good cardiovascular systems, so they can perfuse well. And so for them, poor perfusion, you can pick it up very quickly with delayed capillary refill. You can pick it up by just touching them and feeling their skin temperature and the difference in the demarcation between good perfusion and poor perfusion. They could have decreased peripheral pulses. And one thing to remember, of course, is one of the first signs of poor perfusion in the pediatric patient is an altered level of consciousness. And they normally can handle volume well. We still give 20 per kilo unless it's packed cells. We might be given 10 per kilo, but we still give aliquots of volume and reassess to see where we are. But in general, they can handle volume very well. In contrast, however, the extreme geriatric patient has peripheral vascular disease. What does that mean? They look like they're poorly perfused all the time. Some of these patients, when you look at their feet and their hands, it's like, whoa, it's kind of hard to tell what's going on because their cap refill is 5 on a good day. So poor perfusion for the geriatric patient, we have to look at numbers. We have to look at vital signs. We're looking for hypotension. But, and we'll talk about this again later, remember that in the extreme geriatric patient, a systolic pressure of 110 is the new 90. when you're looking for hypotension, meaning that a systolic pressure of less than 110 is considered hypotension in the geriatric patient, whereas in adults we usually say less than 90. Remember, that number is higher for an indicator of hypotension in the geriatric patient. And these patients can go into congestive heart failure very easily. They're easily overloaded. But did you know, pediatric patients, they have a limited ability to increase their stroke volume, so when they get in trouble, they can't necessarily squeeze out more blood, so they just move it around quicker, and that's why they get tachycardic. They have an increased metabolic rate, so they don't have a lot of reserve there. Their criteria for hypotension really is the decrease in peripheral pulses and decreased perfusion. Their vessels are very compliant and can be very constrictive, and it is easy to miss shock on these patients. Why? Because they can maintain their systolic blood pressure even though they're in fulminant shock until they go over quickly. So, unrecognized shock, it's a problem. So what about the geriatric patient? Their LV, their left ventricle is very stiff, so they have a hard time increasing their perfusion as well. They have aortic valve regurg, so their perfusion, their cardiac output could be decreased just in general. They have increased energy expenditure, meaning they'll tire out quickly just because it takes so much to do anything. And remember, hypotension is defined in the geriatric patient as a systolic pressure of less than 110. So the commonalities between the two, they both can have unrecognized shock, and we could miss it. Adult patients, geriatric patients, often can't mount that tachycardic response, but they become hypotensive. So we're watching systolic pressure for them, and for kids, we're looking for perfusion. So some of the other commonalities, if you've ever tried to start IVs on teeny tiny babies or extreme geriatrics, you know it's a challenge. In the tiny babies, the technique is different. Oftentimes you're not necessarily poking right at the vessel, you're poking near it and threading up, the catheters, etc. are different, but it's very difficult to start an IV if you're not used to starting IVs in infants. And for the geriatric patient, it's really difficult because their tissues are so friable. It's easy to cause skin tears and bleed, and both are at risk for infiltrations. And again, with the medications, they both can be very sensitive to the medications that we're giving them. So we need to start low and go slow. It's better to add more than to give them a whopping dose of, or even a normal dose for intubation per se or for pain, and have them drop their blood pressure and arrest on us. So the main point here again is shock is so easy to miss. So monitor your capnography. Watch for low cardiac output states with your capnography being very, very low. In kids, they can be in fulminant shock even though they have a normal blood pressure. So you really need to go with skin perfusion and brain perfusion as to where they are in shock or not, and not wait for that blood pressure to change. With geriatric patients, you need to be watching for them for a higher systolic blood pressure, recognizing that anything less than 110 is considered hypotension in the geriatric patient. You can't be looking for tachycardia. Oftentimes that's blocked by medications. So let's talk about the disability of both. That's their neuroperfusion and their neurologic status. Again, one of the biggest contrasts in kids, they can have that spinal cord injury without radiologic abnormalities. Their spinal cord could be injured even though their bones are okay. In the geriatric patient, they can have very fragile C-spine bones, and they can break just by torquing them too much. So we have to be very careful with both when we're dealing and manipulating their C-spines. Both of these patients can be very difficult to assess their neurologic status. With an infant, of course, they're not going to talk to you. You also need to recognize in the older pediatric patients, the toddlers and such, depending on where they are in their developmental phase, is how you're going to expect them to respond to you. So you need to know that. In the geriatric patient, it can be very, very challenging, right? Because they can have any one of the 3 Ds. They could have dementia, borderline anyway. They could have depression. or they could have delirium. All of those could be in their normal baseline state. So here they are with a possible head injury, and we're trying to assess their neuro status. Both are very challenging. Traumatic brain injury, the severity may be masked, and this is what I was talking about earlier. We know with infants, they have fontanelles and sutures, and because of that, that will allow blood to accumulate in the brain, in the cranial vault, before they become symptomatic. And with the geriatric patient, they can actually have brain shrinkage as they get older. If they're not actively doing things to keep their mind active, their brain actually can shrink, and that gives more room in that cranial vault, in the skull, to bleed before they become symptomatic and present. Spinal cord injury risks, we talked about that with kids and infants especially. They have those big heads and lax neck muscles, so they could injure their spine very easily. And again, in geriatric patients, you have those bony challenges because of the changes in their age. They both are sensitive to medications. Start low, go slow. And here is the tip for both. You might have to rely on the caretaker to help you assess where they are neurologically as a baseline. Is this normal for them or not? You may well need to ask someone else who knows them well to help you understand what's normal and what's not. So again, the main point, the physiologic and anatomic changes can mask the severity of injury. As you can see on the left part of the screen, that's a lot of room in that brain for that blood to accumulate before it starts pressing on the brain and making them symptomatic. The other thing in the extremes in trauma for both patients, and because of the actual shrinkage of brain tissue in the geriatric patient, giving them more room, again, they could lose blood into their head before they become neurologically symptomatic because nothing's pressing on the brain yet. And also recognize that they both could become hemodynamically unstable just because of a brain injury. Normally in the adult patient, we'll say if you see hemodynamic changes and instability, it's not because of a brain injury. Look for blood loss somewhere else. But in the extremes in trauma, both of them can lose enough blood in their brain that they could become hemodynamically unstable just from an isolated traumatic brain injury. So recognizing that is important. So our interventions, again, between the both of the extremes in population, we must avoid secondary brain injury. And so just what is that? We know that the primary injury is what's happened at the impact. Whatever it was that caused this brain injury, that's the primary impact, primary injury. The body's response to that injury and what happens immediately after that impact is what we're talking about when we talk about secondary brain injury. So as you can see on the slide, you see that dead tissue. That penumbra around there is the area that hasn't declared itself yet. It is at risk for becoming injured just because of the body's physiologic response to that brain injury. So that is the tissue that we're trying to protect. And the best way we can do that is to avoid hypotension, because once they become hypoperfused and hypotension, that area could all become injured. We've got to avoid hypoxia. The brain needs a lot of oxygen when it's injured, and anything that causes ischemia can cause increase in brain injury. So recognize that if we're not monitoring their capnography for perfusion and ventilation and their SATs, that the brain injury that occurred already could become worse while they're in our care because we're not focused and vigilant on those parameters. Hypercarbia. If they are not breathing fast enough and their CO2 goes up, it can cause an increase in that brain injury. Likewise, if they're breathing too fast or we're ventilating for them too fast, we're hyperventilating, that can also cause anoxia to that area and increase the damage and the brain damage. So think about that. It really, really matters. It could be the difference between one of these patients going home with some cognitive changes that they need to rehab versus going home or to a nursing home with a trach and peg. It's very, very important to monitor. The sweet spot for your CO2 in your brain injured patients is 35 to 40. Normally we know it's 35 to 45, but you really want to keep it tight. And hopefully maybe next year we can talk about traumatic brain injury itself in the extremes in trauma and talk more about that. But for now, just recognize that you've got to maintain the capnography between 35 and 40 to prevent secondary brain injury. So let's talk about exposure and emotions. That whole circle of death, hypothermia, coagulopathy, and acidosis we know to be true in trauma patients of all ages. So now let's talk about non-accidental trauma in both patient populations. I was just so saddened and shocked to see non-accidental trauma and the patterns of injury in the geriatric population when I was trauma coordinator. And I knew this to be true for kids, and it was disheartening with this patient population as well, but when I saw it in geriatrics, it just really saddened me all the more. And we used to say this prior to COVID, and now during COVID, we know that it's even gotten worse. But for the pediatric patient who comes in with non-accidental trauma, if it's the devastating neurologic devastation or death, 70% of those patients have been seen in the system for something else in the recent past. Otitis, gastritis, accidental broken bones, lots of different reasons why these kids who were in non-thriving situations would be injured or sick. And they came through our system and we missed it. We weren't looking because maybe we were just looking for the ear infection, etc. Also, statistics will tell you that non-accidental trauma, if it doesn't stop after the first event, that subsequent events not only get more frequent, but more severe. So they're really depending on us to be their advocate. And for whatever reason, any of these patients, especially the extremes, come in our purview, we should always be looking for non-accidental trauma, always be looking for signs and symptoms that they are being injured in their home environments. So we must rule out non-accidental trauma. They're both at high risk. They're unable to defend themselves. And it's the same situation in both extremes. Inconsistent stories about injuries. You can have injuries that aren't consistent with the trauma. You can see bruises at various stages. If you go online and look at a reference called 10, TEN, 4, the number 4, you'll see a great reference for non-accidental trauma for the pediatric patient. Download the poster and put it up. Very, very important. We should all have screening tools, and certainly initially our patient contact in looking at these patients is number one screening. So injury prevention should happen with both. Both groups for sure are susceptible to burns and overdoses, poisonings, falls, all of these things. So we should all be involved in injury prevention. And what about rehab? One of the common bonds between both extremes in trauma is they need early and aggressive intervention. For kids, their bodies are still developing and we really need to intervene quickly with them. And when you think about the geriatric populations, they're already kind of behind the 8 ball with physiologic changes, and so we really, really need to get them in rehab and be aggressive with it. So again, the salient point, pediatric and geriatric trauma patients should be seen at specialty trauma centers. That's straight from the American College of Surgeons. We need to avoid mis-triage. Recognize the things that would delay presentation, brain injury, non-accidental trauma, and recognize that mis-triage is a real deal. So we need to watch for that. The trauma assessment is the same in both your C, ABC, primary and secondary surveys. Shock is so easy to miss in both extremes in patient populations. Recognize that their physiologic and anatomic changes, though they may be different for each patient population, can both mask severe injury in these patient populations. And we must rule out non-accidental trauma in all of our pediatric and geriatric patients. So again, in summary, systematic, focused assessment so we don't miss anything. And trauma can be deceptively life-threatening. They need to be treated appropriately. Severity of injury can be masks, Understand the pitfalls when you're given those medications. Start low, go slow. We can't just rely on vital signs. It could be very deceptive. And be careful for the C-spine. Undue manipulation could cause injury in both. They both require strong advocacy and detective skills. I thank you for listening and appreciate your time. Look forward to any questions you might have.